what we're seeing from them is that children do seem to be, we need to break down what children mean. The youngest children under 10 years old, for example, versus children over 10. And it depends on how the study broke down age. Some of them range from 5 to 9, some of them range from 10 to 14. But what we're seeing is that children in the youngest age groups have a lower seroprevalence, and those that are above 10 seem to have a similar seroprevalence to those that are among older, young adults and above 20 years old, which means that they can be infected, which we've said from the beginning, but they do tend to have more mild disease. In terms of transmission, there's quite a lot that we still need to understand about transmission in children. Many of the schools and many of the countries that imposed these public health and social measures, or so-called lockdown measures, did include closing of schools, although not all did. And we're learning from some countries, as they're opening up some of those restrictions. We have heard of some outbreaks in schools, mainly among the older children. But again, there's a lot that we don't know about transmission among children. With regards to schools and advice on schools, WHO has issued guidance on the safe running of schools and making sure that certain measures are in place. We've also issued guidance on when schools, considerations of when schools can reopen, and that takes into account a lot of different factors that decision makers need to take, whether it relates to the transmission that is occurring in the local area or the catchment area of the schools, the type of school structure it has, the ability for the school to have these to be able to implement the measures like physical distancing, hand washing, etc. And so there's a number of considerations that need to take place. But as you highlighted, children do seem to be less affected, but they can be infected. And that is important. Our understanding of transmission in children is still limited, and we know that overall they tend to have more mild disease, but in some situations they can have severe disease, and we have seen children that have died.
Yes, and thank you, Maria. I think that says it all. I think we've been around, if we cast our minds back over the last couple of months, we've had healthy debates and around everything from long-term care facilities to transmission in dormitories, to transmissions in airplanes, to transmission on public transport, healthcare settings, the workplace, and now schools. And Maria is absolutely correct in that we don't fully understand the full contribution of children to the overall epidemic. The fact remains that when community transmission exists, and when community transmission is intense, children will be exposed to that virus, and children will be part of the transmission cycle. They will be exposed, some will be infected, and they may infect others. What we don't fully understand is the impact on those children in the long term. We know in the short term they tend to have milder infections. We don't know the impact in the long term, and we don't know to what extent they pass that infection on and infect others. But we do know that that can happen. So when we look at that, and we can have the same issues when it comes to the workplace, and we talk about employees in the workplace, and we talk about long-term care facilities and health workers in the facilities and older people and visitors, and to what extent do visitors bring the disease in, or to what extent do health workers participate in transmission. And all of this is in the setting of what's happening in the community. And in communities where transmission has been effectively suppressed, where countries have been successful in driving down transmission of the disease across the board, then you reach a point where everything is safer. The problem we have in some countries right now is that it's very difficult to determine the safety of any environment, because there is just so much transmission going on that all potential environments in which people mix are essentially problematic. And that's a problem. We've all paid a heavy price. Countries around the world have gone into very serious movement restrictions, stay-at-home orders, in order to suppress the virus transmission. And as countries have opened up, in some countries the suppression of the virus has been kept in place. Countries have opened up carefully, sequentially, in a stepwise fashion, and have strengthened their public health architecture, and have strengthened their capacity to investigate clusters and suppress the disease, and in some cases implement subnational or targeted measures at movement restriction or stay-at-home orders. And in that case, schools are part of that. So yes, there is an issue around how much and to what extent children participate in transmission. There are real issues around how schools can be reopened safely, but the best and safest way to reopen schools is in the context of low community transmission that has been effectively suppressed by a broad-based, comprehensive strategy. We can't move from let's deal with the schools and then we all deal with that for a week or two and then let's deal with the workplace or then let's deal with infection in hospitals or long-term care facilities. This is playing whack-a-mole. We have got to focus on a comprehensive, long-term strategy that focuses on everything at one time. We've got to chew gum and walk at the same time, and we keep pulling ourselves down various rabbit holes. Schools are a hugely important part of this. They're a hugely important part of our social, educational architecture. They're the baseline of our civilization. But we can't turn schools into yet another political football in this game. It's not fair on our children. So we have to look at this carefully in the light of the transmission in any given country or any given setting, and we have to make decisions that are based on the best interests of our children, be it their educational or their health interest. And that must be based on data. That must be based on understanding the risks in the specific setting in which schools are. What is the community transmission and what are those risks? And my fear in this is that we create these political footballs that get kicked around the place. And it's for me, we need to get back to what the Director General has just spoken about. Comprehensive strategies, sustained commitment to broad-based virus suppression. If we suppress the virus in our society, in our communities, then our schools can open safely. And there are many countries around the world in which schools are reopening successfully and safely because countries have dealt with the real problem, community transmission. So I would advise us all to look carefully at schools. We will continue to, I think we have a technical advisory group meeting coming up, Maria, we want to speak to that. We're bringing experts together from all over the world once more to look at how we manage and open schools in a safe and effective way. But please, let us not turn this into yet another political football.
Only add that we have a technical advisory group that's been pulled together to advise on us on educational institutions, specifically around how we do this safely. And it's a global collaboration. There's a large number of scientists that are helping to advise us on this. We have our second meeting this week, and that is something that we have specifically pulled together for this, because it is such a complex issue and it is such an important issue for all of us.
Thank you very much, Drs. Ryan and Drs. Van Kerkhoff. Our next question comes from Catalan, from Nazare Romero from the Catalan News Agency. Nazare, please unmute yourself and go ahead.
Hello, can you hear me?
Very well. Please go ahead.
So thank you very much for taking my question. I'll ask in Spanish, if I may. En los últimos días hemos visto cómo se han detectado nuevos brotes en Europa, por ejemplo en España, y quería saber si les preocupan estos nuevos brotes en Europa, donde la situación parecía estar más bajo control que en otros sitios del mundo. Y también quería saber cuáles son sus recomendaciones cuando se detectan brotes locales, si recomiendan medidas de confinamiento o cualquier otra medida es mejor. Muchas gracias.
So thank you for the question. I think this is exactly what the Director General was speaking to today. And we spoke at our last press conference about this, and that in many countries that have been able to suppress transmission, there is always the possibility of resurgence. And what is really important is that the countries that have used this time and have spent the time to build this public health infrastructure, the workforce in place, the surveillance in place, the strategies in place, to act fast when there is an upsurge in cases, whether it's a small cluster or whether it's something that has an outbreak that has started, the opportunity is to act fast and to apply the same comprehensive approach, informing your public, saying where this virus is, what are we doing to suppress it, what role you can play as an individual, what role we are playing as leaders to be able to bring these outbreaks under control. And I think that if the infrastructure is in place, if that workforce is in place to find cases, test cases, isolate cases, carry out contact tracing, quarantining contacts, and putting in place perhaps some restrictive measures in a localized area So not go into the full-on nationwide lockdown, but to really apply measures at the lowest administrative level as possible to help support the outbreak response. That is something that we see going forward, where that can be done in a data-driven way. So there are opportunities to suppress these outbreaks, these resurgence, and these pockets of activity very, very quickly. And we're seeing a number of countries really be successful in doing that very quickly. But it takes a surveillance system in place to rapidly identify the cases so that you know when you need and where you need to act fast.
Thank you very much, Dr. Van Kerkhoff. Our next question comes from China, from Ye Li, from the GENEVA news agency. Please go unmute yourself and please go ahead.
Okay, thank you for taking my question. Can you hear me?
Very well. Please go ahead.
Okay, good afternoon. I have a question about the origin of the virus. We noticed that the last week before last week, Spanish researchers tested coronavirus in wastewater sample of March last year, after the Brazil experts announced the similar findings. So based on these findings, an Oxford expert pointed out that the coronavirus may have been lying dormant across the world until emerging under favorable conditions, so rather than originating in China. So I know we have asked such kind of questions before, but I wonder what's the new learning or understanding of WHO on this issue of wasted water? Thank you.
Certainly, surveillance of wastewater is a really good way at looking sometimes at the long-term epidemiology of any disease. We use surveys of wastewater, for example, to track poliovirus around the world, and it's a very effective way of knowing where a virus is and what circulating strains are. We've certainly seen the same for cholera and other diseases. So the environmental surveillance in general is a very, very useful way to supplement human surveillance when it comes to the understanding of disease. And we congratulate our scientific colleagues for using those methods and innovations to look at the potential that this disease was present earlier than may have been previously suspected. But when it comes to investigating human disease, and the Director General has spoken of this many times, you need to go to the epicenter and work from there. We're very, very clear. The first human cases of this disease were picked up in Wuhan, the first clusters of disease in Wuhan, China, and then subsequently spread from there. And that is where the starting point lies for a full understanding of the origins of this virus in the animal kingdom. And the animal source, or the intermediate hosts, have not been determined. We assume the primary host is a bat, but certainly that's also to be fully determined. But that is the source of the human cases, or the first evidence of human cases. The question remains then, what were the incident that allowed the transfer of that disease from animals to humans? Where did that occur? And that can occur in the area in which the first human cases are noticed, or can occur far away from there. We've certainly seen in Ebola and other diseases that the first human cases can be unnoticed, and then by the time you pick the disease up, it's already somewhere else. And that's been very often the case in Ebola. The first cases that are noticed are in health workers. Well, we don't assume that the bats came and bit health workers. What usually is the case is that there's a trail of cases going back over some time, and at some point historically there was a transfer of disease from the animals to humans. So it is a detective story in that regard, and you have to go where the data and the science leads. We keep saying we have to follow the science, and when it comes to understanding the origins of disease, you have to follow the science too. And it's really, really, really important that ultimately, and I'm sure our Chinese colleagues are doing this already, they have tremendous capacities for disease investigation and scientific understanding, that we start where the disease began in humans, or where the first cases of disease occurred in humans, and we work from there, and we keep an open mind. And it's really important that we keep an open mind. But you can't close your mind based on one or two other findings elsewhere. That becomes a distraction. And again, you end up being led down different alleyways that are not helpful. The data and the evidence should lead where it leads, and this investigation and understanding of how the disease transmitted and where and by what animal did this disease breach the barrier to humans needs to be understood. It's extremely important that it is understood, and that investigation and that scientific understanding should start at where the first clusters of human cases were detected, and that's in Wuhan in China. Maria?
Okay, thank you.
Oh.
Thank you, Mike. Sorry, Maria. So I have another commitment, so I will leave you with my colleagues, Mike, Maria, and Soumya, and hope to see you in our next session. Thank you.
Yes, so just to supplement what Mike has said, it is as he said. We listen and we learn. We see what investigations and studies are underway. We look what surveillance has happened, and we follow the science. And so it is a bit of detective work in that sense, where you're following the clues. And there is quite some work to be done. I mean, if you think about the identification of SARS, the first SARS virus, it took over a year. If you look at MERS, it took years. If you look at MERS, that took us over a year. So it does take some time. So I think we need to manage the expectations about finding the intermediate host and how that takes place. But I think what is important is that there is this global collaboration. There's a whole network of scientists that exist globally, including scientists from China, across the US, across Europe, across many different countries, all continents, that always look for these emerging pathogens. And so there's a large amount of work that's underway. We will follow the science. We are open to following that. And I think we are all committed to find the intermediate host because of its public health importance. Knowing what the intermediate host is will help us to prevent this from happening again.
Thank you very much, Drs. Ryan and Dr. Van Kerkhove. The next question comes from Nairobi, from Sarah Jerving from DevEx. Sarah, could you kindly unmute yourself and please go ahead?
Thanks for taking my question. Is the incubation period and the time frame in which a test result would return positive the same? Would someone need to wait the 14 days after exposure to feel comfortable that a test result is accurate? And is the incubation time frame still believed to be a maximum of 14 days, or could it be longer?
So I can start with that. That's quite a few questions in one, actually. So well done to you. So the incubation period is the point of time where somebody is exposed to the point of time where they develop symptoms, and it's believed to be between 1 and 14 days. There are always exceptions. We should say that there's always exceptions, but the majority, the average, is between 5 and 6 days. So most people will develop symptoms within 5 to 6 days. Your question about the testing is a good one, because we often get questions in terms of our testing strategy of when is the most appropriate time to test someone. So what we do within our case definitions and our recommendations is to test somebody when they develop symptoms. However, saying that, we also recommend contact tracing. So people who are contacts go into quarantine, which means they're essentially removed from other people so that they can't pass the virus on. And some of those contacts are tested. They are tested when they develop symptoms, but some of those individuals are tested when they don't have symptoms, which is why we're seeing some asymptomatic cases being detected. If that testing is going to be done, it should be done before that 14 days is up. But it does depend on a lot of characteristics of what type of test is done, what sample is collected, whether it's an upper respiratory sample or a lower respiratory sample. So there are a lot of different factors that are in play when it comes to when is the most appropriate time to take a sample from an individual.
Just to point you well, I mean, there's some excellent publications out there around issues like this and around broader issues, but there is a very good publication in JAMA this week, which is a review of all of the key parameters around the disease, like transmission and incubation and prognosis and so many other factors, the epidemiology. And if there is probably one it may be a little complex scientifically in parts, but for journalists out there who really want to get an overview of much of what we know right now globally around the disease, Wersinger et al. Have a very good paper this week in JAMA, which kind of goes across the whole range of what we know about this disease. Because I think we said it here last week, we're all in a deluge, a tsunami of scientific publications, and sometimes when scientific colleagues synthesize that into something a bit more manageable, it makes things much easier. So I just point you to publications like that where you can pick up a lot of information regarding what we know in a more synthetic fashion. Very, very helpful indeed.
Thank you, Dr. Ryan and Dr. Van Kerkhoff. No, okay, great. So our next question is for Imogen Fuchs of the BBC. Imogen, can you unmute yourself and go ahead, please?
Hi, Margaret, thanks very much. It was primarily a question for Dr. Tedros, but Mike and Maria, I think, I'm sure you can answer it as well. Dr. Tedros said the Americas remained the epicenter of the pandemic. And I'm just wondering, looking at the, really big increases in cases that we have seen, particularly over this last weekend, on a public health basis, what's gone wrong and what needs to be done as a matter of urgency?
If we look at the Americas as a whole, I think both, and the DG alluded to this, in many circumstances, countries made some progress in suppressing transmission, but certainly the reopenings in those countries have led to more intense transmission, and now a number of countries face a scenario in which there's increasing and sometimes exponential transmission, a very difficult situation to face, and not necessarily with the option to impose these so-called lockdowns again because of the economic damage and the community acceptance of those. But as Tedros said, there is no situation which cannot be faced, and I think this is the issue, is to turn and face the fire, turn and face the problem, and accept that it's going to take time. It's going to require a huge commitment on the part of government and individuals in a number of countries to turn this around. And it's not just government, it's individuals, the choices we make. I think I spoke about that last week. There are choices that we all make that can either increase or decrease the risk of transmission. But there are choices that governments make that can either increase or decrease the risk of transmission. We need to re-establish trust, communication, and strong government-led strategies that can turn this around. Some of that may require limited or geographically focused lockdowns that suppress transmission in specific areas and where transmission is frankly out of control. But that is not the case in all places. All countries in the Americas have areas in their countries in which transmission is at a reasonably low level. But some areas in almost all countries have areas of intense transmission. And in those situations, absolute individual and community adherence to social distancing, hygiene, the wearing of masks when appropriate, all of those different things. If everybody does that, then we will suppress transmission, avoiding crowded places. But if people continue to frequent crowded places without taking the necessary precautions, if people aren't practicing physical distancing, if people aren't practicing hygiene, if people aren't wearing masks in the proper settings, then the disease will continue to transmit. At the same time, governments have to support communities in that, and governments have to be, again, Tedros spoke to it very clearly, we need to be absolutely clear and consistent in our messaging to our citizens. And it's got to be easy for citizens to comply. It's got to be facilitated, and it's got to be supported. So, and within all of that, as we get control back of the disease, and I can't say this strongly enough, the countries that have put in place strong public health surveillance architecture while they've been dealing with their lockdowns are now emerging from those lockdowns in a stepwise fashion, and they're replacing lockdowns with strong public health capacity to detect, to test, to quarantine and to treat cases. And countries that have taken that path are having relative success in continuing to suppress the virus. But as I've said here before, we need to learn to live with this virus. Expecting that we will eradicate or eliminate this virus in the coming months is not realistic. And also, believing that magically we will get a perfect vaccine that everyone will have access to is also not realistic. The history of vaccines are that we can and will develop a vaccine. The question mark is, how effective will that vaccine be? And more importantly and more worryingly, who will get that vaccine? And will that distribution be fair and equitable? But as Tedros has said, there are things we can do now. There are tools we have at our disposal now. If we apply them, and if we apply them systematically, and if communities and individuals buy into that and trust that their behaviour will be supported by government, and we can work together collectively to drive down and suppress transmission. The positive news in this is that in many countries death rates have fallen, and we are getting better at treating cases, we're getting better at diagnosing cases early, and we need to continue that. We need to suppress mortality, suppress transmission, we need to support communities, and we need clear and strong government leadership. And that doesn't matter where you are, but that's all the more important in countries that are now suffering very, very exponential transmission, which is very, very worrying.
Thanks, Mike. I want to speak to the individual. So as Mike has said, it's not only about leadership, it's about individuals and what individuals do. And everyone on the planet needs to know what role they have to play and to be informed about what this virus is, where this virus is circulating, especially in the areas where you live, the areas where you work, the areas that you want to travel in. All of this is important. There's so much that you can do yourself to protect yourself from getting infected and to prevent yourself from passing the virus on to others. And please make good choices. I know that there are a lot of things that we want to be doing right now, but there aren't necessarily a lot of things that we need to be doing right now. There are many people, essential workers, who cannot stay at home. There are many people who are caring for patients in hospitals who cannot stay at home. And if you can, and if you can help, and if you are asked to, please stay home. You can practice physical distancing from others. You can avoid crowded places. You can avoid places that have enclosed settings that have poor ventilation. You can clean your hands. You can practice respiratory etiquette. You can wear a mask if you cannot do physical distancing. There are so many things that you could be doing, talking to your children, explaining to them the risks. Everyone has a role to play. And this is far from over. So we all have to play our part.
Thank you very much, Drs. Ryan and Van Kerkhove. We have time for one more question. He's been waiting for a long time, and so he gets the last question. It's Jamie from Associated Press, Jamie Keaton. Jamie, please go ahead.
As okay, Margaret, my question was for Dr. Tedros. Thanks.
Okay, well, Dr. Ryan's got an update on Ebola because last week we promised that we would give that updated situation. So, Dr. Ryan, please go ahead.
Yeah, this one goes out to Helen Branswell. Sorry, Helen, the dog ate my homework on Friday. I'm back, suitably contrite. As of the 12th of July, we've had 48 confirmed cases and 3 probable cases reported from Equator Province in north-western DRC. We've had 17 deaths of confirmed cases and the three deaths of the 3 probable cases, 11 survivors. We've had 21 affected health areas in 6 health zones in Equator. And that does, while the numbers are low, that does represent a broad geographic extent of the virus, and that is of a concern. While the numbers are quite low in each health zone, any one of those individual cases can result in amplification of disease. In terms of the areas that are affected, there are 5 zones that we've had cases in the last 21 days, and most of the zones, in fact, have had a case in the last 7 to 10 days. So we're still within that incubation period for another wave of cases in the zones of Bikoro, in Balomba, in Iboko, in Lutumbe, and in Bandaka itself. In terms of the age and sex distribution, males predominate amongst the cases. Females represent 43% of cases, and children less than 18, 6% of cases. In terms of the epidemiologic links, at the beginning of the outbreak, as is normal in many Ebola outbreaks, it's difficult to make the association between cases because sometimes there are difficult exposure histories, and particularly when people have already died. But at present, the documented, at the beginning of the outbreak in the first week, 75% of cases had no documented epidemiologic link. From the 29th of June to the 5th of July, 33% had no documented link, but all cases in the last week have had documented epilinks to other cases. That's good news. The difficult part of that is that the proportion of people who are registered and followed as contacts is less than half. And that means that half of cases are not being actively followed as contacts when they're diagnosed. And again, while the numbers of those are very, very small, that is not a good parameter. And again, in terms of deaths at community level, where we've seen 9 deaths in the community, again, they all represent opportunities for disease transmission. At the moment, as of July the 11th, we're tracking 5,580 contacts across a very, very large and difficult geographic zone with extreme logistics. We've managed on a daily basis to follow 4,977, or 89%, nearly 90% of those contacts are followed on a daily basis, which is good performance in the context of the extreme logistics in the area, but it also means that 10% of contacts are not followed, and that in itself is a concern. In terms of community alerts, we're investigating or detecting about between 500 and 600 alerts at community level every day. Of them, 25% are validated as suspect cases, and then those individuals are tested. There are still challenges in testing. We've very recently established testing capacity in Bakura, which is to the south. So we now have testing capacities in all of the affected health zones, and we have clinical capacity with partners in all of the affected health zones. Just to say that the distances, the logistics, and the demands on all of the teams, the ministry teams, the partner teams, and WHO teams are extreme. It is not the same context as North Kivu. We don't have necessarily the same security issues, but we do have very, very demanding logistics and distance and living conditions for staff, and the condition of the roads, etc. We've vaccinated thousands of people with our vaccination teams, and we're very lucky to have that those vaccination teams in place, and equally so, therapeutics are in the field and now being actively used to treat cases. The R0 for the last 2 weeks of June was 1.7, which means, technically each case is generating more than one other case. So this is still an active, very active outbreak, and I would say it is still a great concern. The Equator province is on the River Congo. It is also across the river from 2 other countries. It is a very, very large geographic area. Communities are linked and people do travel long distances. So there are a number of features of this epidemic that are of concern. Very much thank the Government of Congo for its leadership, the partners in the UN and the NGO system for the support they're providing. But I would caution everyone that while the numbers in this event are low, again, it's in the era of COVID, it's very important that we do not take our eyes off these other emerging diseases, and we saw in North Kivu and in other previous outbreaks of Ebola that these can get out of control very easily. We're very focused on continuing to support the Government of Congo in eliminating Ebola once more in this situation. Thank you.
Thank you very much, Dr. Ryan. And with that, I'll close this press conference for today. We'll send the audio file, as usual, to the Globalist, and the next press conference will be on Friday. That's Friday, the end of this week. We'll look forward to speaking with you then. Goodbye.